Oh.
If everyone could take their seats, we're going to get started here in just a minute.
Good evening. It's a very exciting event tonight, which I'll talk about in a second. So, Matter, I'm Stephen Collins, the CEO of Matter. For those of you who don't know that, for those of you who aren't intimately familiar with Matter or as familiar with Matter as I am, we're a healthcare technology incubator and innovation hub. We're about 2 years old. Our mission is really to bring entrepreneurs together with industry leaders and hospital executives and investors and mentors and a community that can really help them develop solutions to meaningful problems in healthcare in the most efficient way and bring those solutions to market. We work with about 200 healthcare startups, increasingly around the world. We work with 70 partners, big healthcare companies, hospital systems, universities, also increasingly, at least national. We are a public-private partnership. We're a nonprofit organization initially funded by the state, privately operated. Here on out, as I mentioned, we've been open for 2 years, and this is the culmination tonight of the first entrepreneurial challenge that we've ever run. So it started about 6 months ago. You're going to hear a lot more about it tonight, but I just have to say we did it. We ran one and we opened it up, and so we are really excited about that, and hopefully you're excited about it as well, and thanks for joining us. There are a lot of people here and a lot of organizations here who we partnered with and who participated and donated their time or their money or their expertise or all of the above or their equipment, and we very much appreciate it. Certainly couldn't have done this without OSF Healthcare, who's been a partner of ours ever since the beginning, really world leaders and world experts in simulation. You've probably all seen the OSF simulation stage. If you haven't, it's over there and you can pop your head in. They really helped us put that together. Allscripts, it's one of the leading EMR companies that happens to be headquartered a few floors above us in this building. Really one of the real success stories of Chicago, probably Chicago entrepreneurship period, but certainly Chicago healthcare technology. And they have an instance of their Sunrise EMR system that's installed in the simulation stage. And Hillrom, which transplanted its headquarters to Chicago a few years ago, and has been certainly very helpful to us. I was going to make some wisecrack about how that accelerated the growth of their business, but I actually don't know anything about that. But they have a huge share of beds and are increasingly expanding into additional product lines and additional offerings. It's been really interesting getting to know that company and sort of as they have transitioned over the last 5 or 6 years, and they've been a great partner of ours as well. So you can see a bunch of Hillrom and Welsh Allen products in there as well that have been very helpful and very important as we've set it up as our own little miniature observation unit. Thanks to all the mentors who have donated and participated in our time. Thanks to the judges who are going to be wrapping this thing up. Thanks to all the teams who've participated. Thanks to all of you for coming. Thanks to Arun for really working a lot on this, and Sam for really spearheading it. And with that, I am going to turn things over to Arun, who's our program director, and who's going to take you through the rest of the evening. So thanks very much for being here, and welcome, Arun.
Thank you. Terrific. Thank you, Steve, and good evening, everybody. Welcome to Matter, for those of you that are here for the first time. I wanted to just take a few minutes and share a little bit of background with some of you to give you a sense of how this challenge came to be, and I wanted to also take a few minutes to acknowledge and thank a few people in addition to our sponsors who really made this evening possible and kind of why we're here. But let me just share a little bit of background for those of you to understand sort of how we are actually culminating this evening with the Observation Unit Challenge. So last fall, there were a few conversations that were initiated with our partners at Hill-Rom around observation unit medicine, and really trying to understand what are some of the challenges and innovation opportunities that exist within that space. And it was around this time that there were some macro shifts as well that were increasing the interest of this area. Sort of the 2 midnight rule and how that affected reimbursement, the payment differentials between inpatient care and observation unit care. So it sort of all kind of converged together as a very interesting area of innovation. And then concurrently, as Steve mentioned, the advent of our stage here, which we're going to have a demo of one of our companies there after the presentations. So I encourage all of you to take a look through there. All of this began and then was spearheaded by some folks at Matter who in true entrepreneurial fashion took sort of a market approach to say, well, let's go talk to some hospitals. Let's go talk to some physicians to really understand what these challenges are. And so there were about a dozen interviews, large, small hospitals, and it was sort of confirmed and validated that this is really an area of interest. And there were actually 3 challenge areas that were identified. So one was really understanding how do patients actually triage, how do hospitals actually triage patients through the observation? How is that decision made? What decision support tools are used? That's one area of challenge. The second one was around patient education and patient communication. Once a patient's in an observation unit, what are some ways to actually communicate with that patient, have them understand why they're there, how long they're going to be there, and what the next steps might be. And then the third one was really solutions to really help understand how to increase throughput through the observation unit so it doesn't become a bottleneck within the hospital. So those were sort of the 3 areas that were highlighted, and we opened it up to the broader challenge, the capital C, to the community of entrepreneurs and students. And we were excited to have all the way from undergrad students to graduate students, med students, and entrepreneurs who were really trying to understand the space and look at it and try to address one of those 3 challenge areas. And just for your FYI, the first milestone was really a video exec summary where we asked entrepreneurs to talk a little bit about the challenge that they're addressing, why it was of interest, and some thoughts about how they might tackle it. The ones that made it through that first milestone made it to the second milestone where they had to put a little bit more meat to the bone around the value proposition, the solution. Those that made it through the second milestone made it into the third and now have put together a little bit more of a robust business case. And what you're going to see here tonight are sort of the last 3 standing in terms of those stories. So it'll be interesting to hear their stories and hear about what types of solutions they have offered. So I want to just take a minute to introduce our judges, or actually have them come up and introduce themselves. Before we do that, in addition to thanking the sponsors that Steve did, I also want to call out a couple of people who were really instrumental in this. So one is Sharif Ghanem. Sharif, can you stand up? Who really helped, a member of the Matter family who really helped spearhead this when it first started. And I also want to acknowledge Cody Booth over at Accenture. Cody, thank you. The Accenture team was really vital in terms of helping to distill down and filter through all of the applications and all of the proposals. So thank you guys very much, and thank you to the whole Matter team that really made this happen. And lastly, a thanks to, on the last page of your agenda, you will actually see a list of all our observation unit mentors. And as we've all kind of learned, to develop any type of solution in a space like this, you really need to rely heavily on mentors and folks who are in the trenches and who know this space, who can give good guidance. And we were very, very fortunate to have a number of mentors who worked with our companies throughout the way. So for those of you that are in the room, those of you that are watching, thank you very much to all of you for your support in that. So with that, I'd like to introduce our judges. If you guys wouldn't mind just coming up for 1 second. And just wanted to have you hear from them, a little bit of their intro. Just take a minute to 2 minutes to introduce yourselves and share a little bit about why you think observation unit is interesting, why you're here. And then once we complete that, we'll dive into the presentations.
Mine's a little bit of a duh. My name is Karissa Tayo. I am the medical director of the observation unit at the University of Illinois. That's why it's important and interesting to me. I first heard about the Matter Challenge when they were looking for mentors, and in fact, when they were exploring the idea of this was something worthwhile to actually go ahead and pursue. And I am one of those docs who assembled a team from the ground up, created the unit within my hospital where we hadn't been doing observation services in any kind of realistic way before then. And I'm very excited to see the outcome of this whole prospect. So many of the ideas were so extraordinary and will make a difference. Downstream, medicine really is going one of two ways. You're either going to be in the intensive care unit or you're going to be under where things are headed. So all of these efforts have been of great value.
Hi, my name is Craig Myerson. I'm here from Welch Allen, but we are now part of Hillrom. So as was mentioned earlier, Hillrom has been traditionally a bed company, but Welch Allen, we have a very large presence in the hospital for patient monitoring, which is where I've spent about 15 years of my career. So observation unit is an excellent place where it's very patient-centric, looking to do some more monitoring and really looking at kind of new solutions for making healthcare better. So I'm excited to learn about all the different products here tonight.
I'm Eric Kins from Allscripts, Chief Innovation Officer. As Steve mentioned, we're 8 floors above here. We have one of the largest footprints in both acute and ambulatory EMRs kind of internationally. So this fits our sweet spot perfectly. I'm really looking forward to hearing all of the presentations and coming out with a winner. Congratulations.
I'm Rob Jeanettin. I'm the Director of Innovation Partnerships at OSF Healthcare, and so really excited not only to be a partner here at Matter, but with this challenge specifically. We know there's a lot of challenges surrounding observation units and observation patients, so I am really looking forward to these solutions, so I won't keep you anymore.
Thank you, sir. As well as IDEO. IDEO was a great partner of ours as well in those early stages as we learned more about the space. So logistics, each company's got 12 minutes. There'll be 5 minutes of Q&A just from the judges. There will be an opportunity after the presentations outside in the common area. Some of our companies will be demoing their solutions. And so we encourage you to grab food and drink afterwards and mingle with them. All right. Any questions? Everybody's good? Ready? All right. We are going to start with Twiage. as our first presenter.
I thought it was 10 minutes, so now I have an extra 2 minutes, so nice. All right, so nice to meet you. Well, I am so excited to be here today. Good evening. My name is Yitting, and I am really proud to represent my team at Twiage. I am a practicing physician, and I'm the founder of Twiage. And when Matter first came out with this challenge, as Arun mentioned, they set out with 3 focus areas. And what we'll be talking about today is the challenge of increasing throughput. You see, a well-run observation unit can actually save a single hospital $4.6 million every year. That sounds like an amazing opportunity. It's also quite difficult. In fact, a lot of observation units, especially being so new, struggle with achieving this. In fact, a poorly run observation unit can actually turn out to be quite costly. And so we really set out to really figure out what were the pain points, what were the challenges that observation units were facing. And we interviewed 18 Matter experts and talked to 27 different hospitals. And we heard a resounding theme, something that came over and over again. And it, it was that fragmented communication and coordination really hurt the team. It caused confusion and poor teamwork on the team, where doctors and nurses and case managers weren't really working in sync and time would pass by. And that would lead to delays in documentation, delays in making a disposition decision, whether the patient needed to go home or go upstairs to be admitted. And when those delays happened, it led to longer length of stays for patients, which, of course, leads to lower patient satisfaction. And at Twiage, our team heard this over and over and over again. And we said, this really sounds pretty familiar. You see, we're really experienced in a parallel space, that ambulance to hospital transport. And you can see that fragmented communication between an ambulance and a hospital leads to a lot of problems. And we've really looked in that space quite well. And so we thought, are there opportunities to take that learning, especially in the ED space, and see if it could apply to observation medicine? And what could our experts teach us about that? And so with that research and our insights, we decided to tackle this problem and think about an observation tracker. It's a live visual tracker of all your patients in an observation unit. And we can customize each protocol for, let's say, a rule-out MI or a COPD, and actually stage it to specific target disposition and allow hospitals to protocolize what they want to see in their observation targets. We then track the length of stay very clearly for every single patient, so that's clearly visible for every member of the care team. And when they get within 2 hours of their target disposition time, we actually flip the numbers count down in red, so that every member can start triggering themselves and start thinking, should I be actually thinking about disposition? What is holding up this patient's decision? And is this patient not better and needs to actually go upstairs? You can see also on this tracker that we track the labs and the tests that have been ordered and whether those tests have come back. Another really important thing about a tracker. And lastly, we even can actually send a non-PHI version of this tracker to allow a patient-facing view, kind of like an airport airline trackers, where every patient can actually see their status, what's holding them up, and what's their targeted time. But we also know that it can't stop there. In fact, busy doctors or nurses in an emergency department, they're always on the go. They're always looking and working on other things. And so they're not going to be captive and looking at a single dashboard. And so we created a mobile interface. And this mobile interface is important because it's able to alert them of lab results and other test results that come back. It also can actually give them an alert for documentation milestones or a disposition milestone. So your phone will buzz to say, you know, it's about time to write an update. You know, it's about time they're about to meet your disposition target. Do you have a message back to your team? And of course, it's incredibly important to have an opportunity to have the entire team speak together. From the nurse to ask a quick question like, what's going on? Are we actually going to get this patient sent home? Do we need PT to evaluate this patient? That can be easily done on a team chat, all within the same app. We believe that this can really deliver value to hospitals. You see, it gives situational awareness to the entire care team, all on just simply one screen and mobilely on a patient's phone. It also provides the entire team with easier, timely documentation and decisions, which of course helps reduce the length of stay and increases throughput. And hospitals and observation units that have faster throughput have higher patient satisfaction. And we think that we've approached this in a way that's fairly unique among the competition. You see, there's a lot of trackers out there, some from EMR vendors, some that are very generalized to more specific to the observation space. And while some of them have kind of spanned the gamut of general to observation focused and with specific tracker measurements, none of them focus on the team coordination aspect. All of them require clinicians to continually check a tracker to see if things have come back, to see if a lab has come back. And that is one of the biggest challenges. None of them have attached that to date. Our target market, we have a clear visual of how this will happen. The observation units are generally in larger hospitals, and so we like to target dedicated observations first. And these are about the 1,300 hospitals that have greater than 200 beds, just as a proxy. And then we like to target the next level hospitals, smaller hospitals. Maybe they're not thinking about or just starting to think about having a dedicated observation units. But even if they don't have an observation unit itself, they have observation patients for sure. And in fact, it's almost harder to track observation patients when they're not on a unit. And so having some system that can allow you to track a patient across your beds and units might be really helpful for these patients as well. Our business model is simple. We charge an annual subscription fee based on the number of observation unit beds. And my average to about $20,000 to $50,000 every year. We also charge a one-time implementation fee that will cover the cost of the EMR integration. We believe our business model with this structure would be about $50 million in total market opportunity. So what's our go-to-market strategy? Well, we think that we should start by conducting a proof of concept pilot. And that's really important to get the data that we need. To do this, we'd like to leverage Twiage's existing ED relationships to achieve early validation. And once we've gone the data to validate, we'd like to go to market and tell our story at trade shows and conferences, publish studies to show our outcomes, improvements, and our return on investment, and partner with ED consulting firms and healthcare IT firms to expand our sales channels. And we believe we have the team to win. I am incredibly proud to be part of a company that has the clinical, the technical, and the business expertise to make an award-winning product. We are also incredibly excited to be joined for this challenge by a team of an ED physician who has direct observation experience, by a former ED operations manager, and two MHA students who are just getting their degrees this summer and who just started their jobs at Johns Hopkins and VNS in New York. We have a clear view of what we need to do next to make this a success. First, we will leverage our existing dashboard and app infrastructure. These are things that we've already built out for our known product. The customizable protocols, the time measurements, alerting and chat, these are existing features that we already have. We'll start there and then customize that program for observation medicine. We'll invest in that and simultaneously identify a beta partner along with one of our existing ED relationships who might be interested in using Twiage in their observation unit. We'll then work together to do that EMR integration through our partner. And finally, all to conduct an outcome study that will take probably 6 to 9 months to really make sure that we are solving their pain points and delivering a return on investment. Now, we know that there are risks. There's always risks in an entrepreneurial venture. Somebody says, you know, integrating with an EMR is slow and costly, and that's a lot for just an idea. But we think we can mitigate this. We already have existing hospital relationships. We've already passed their IT security review. We are a known entity to them. We can actually use that relationship to speed up our ability to work with these hospitals and de-risk the ability to do a pilot. It's also possible that a big vendor out there can come in and say, we're going to do and steal your idea, Twiage. That's entirely possible. From our experience, though, a lot of these large vendors are really focused on other things. They've been slow to innovate, and while they've continued to try to build upon their trackers, none of them have ever focused on a team coordination the way that Twiage does. None of them have tackled the mobile aspect of this. We think it'll take them a while and a major shift in culture to actually do that. So we really think we built something here that will solve pain points for observation units to help these units increase their throughput and improve their patient satisfaction. Thank you so much for the opportunity to be here today to represent my team. We'd love to have your questions. Thank you so much.
I'd be happy to start. So it's interesting. I love the mobile device aspect of this, but I'm concerned because of two things. I work in a shop where we have residents that roll in, and we have physicians who are very particular about what goes on their phones. Do you guys have an alternative option to kind of send your reminders that are not necessarily mobile based? Can you ping somebody while they're working on the EHR, face forward into the computer who's not in your workspace for the triage screen?
Yeah, I think there's definitely two ways that we can do it. So we have the same challenge today with our existing Twiage product, where most charge nurses don't want to be on their phones for patient care. They want to be using the same desktop where they're charting. And so we use the Twiage alerter to send instant alerts on the computer. It's a background application process that starts when they start up. So it just actually sits in the so that actually can work for them. We can also send what are called toasts, so small updates. Kind of when your bank sends a pop-up and it starts flashing on a browser screen that says, hey, you're about to be signed off. We can do something very similar to that. So that wouldn't be a very difficult enhancement. In general, we think that for younger generation of clinicians, they're really getting very push reminders. So they don't have to document on the mobile app. They don't have to do anything else other than just kind of get a quick message, almost like a text message that says, results are back for Mr. Johnson. That will trigger them to go back on the computer and finish anything. Almost everything we've heard is it's not that doctors don't want to do things in a timely manner. It's that they were so busy focusing on another patient or getting something else done that they didn't realize that the labs had come back 30 minutes ago. And so they are now delayed in acting on it.
Do you guys have on-the-fly protocol modification? Because none of our patients actually fit into the cookie cutter. If you have to add one additional test or one thing that might actually affect your anticipated length of stay, is there any room to modify the anticipated length of stay?
Absolutely. I think that's definitely possible. So the way Twiage works is that we have some basic tags. So we actually have every protocol is basically discrete variables where you can say, select if this applies to you. It's a very, very simple version of like interqual, but much shorter. And so the moment you can actually tap another one, we can actually use that in our algorithm to target a time. That would really help. We do that for ambulances that are coming in, so we'll use the same here.
Great. I've got one kind of related to what Karissa brought up with respect to the inboxes. I'll agree with you in some respects, seeing as our name was up there as kind of running something similar. I know, it gets exciting. But what I would say is that what we've seen is that another inbox or another app where we've got to deal with this is a challenge. And we've seen this time and time again. We've seen some group-driven applications and things like that try to make it, but I haven't seen anything that's really come to the forefront and kind of beat everyone else out. Do you have any ideas about tighter integration with the main inbox, messages inbox and things like that might be in the in the clinical system? How would you deal with that?
I actually have very strong views about this because I'm a primary care doc, so I'm a clinician myself, and I use Epic clinically, and so my inbox is crazy, and so I really hate my inbox. So I understand these challenges. I'll give you an example. So when I was a resident, and you're the first response for all these patients. And you're responsible for following up on all these labs. We used to have a system that would actually allow us to page labs. You can imagine that a doctor hates their pager, but to have doctors page labs to their pager shows how important that is to be paged. When my hospital moved over to Epic, we lost that function. And that was one of the major laments of all the residents. And so it's not really about, can you send me another inbox? Because when that inbox message comes, unless I'm at the computer actively checking my inbox, I'm not going to get it. I want that alert to say, and just quickly glance and be like, do I need to deal with this or not? And I think it's a different style. So to give another example of another entrepreneur company that's done really well, Herald Health, their entire system is about if then that. and they build that for EMRs. And so their success is just a building upon the fact that EMRs currently don't do that. I think there's actually a huge opportunity to do that. Twiage is a very
So if you're at the computer, the message will pop up there. But if you're away from the computer, the message might pop up.
That's right. That's right. Because I view this, my inbox, I view as like my email. I don't have to have it all the time. I view these things like text messages. When your kid wants to know something, you get to see it. You can say it. You can choose to ignore it, but you get it on push to your phone, and that's the point that's important.
And how big of a pivot was it for you guys to move to sort of adding this functionality? Kind of a little module add-on, or was it sort of a big re-architecture?
I think it is. There's some areas that are some re-architectures, but I think fundamentally the protocols we already do. The timers we had to adjust a little bit. Currently, they only count up. Now they have to kind of know to count up and count down. So there's slight modifications, but I think the biggest lift here will actually be the deep EMR integrations, because with the lab and CT tests and all the other tests, we're required to do more and deeper integrations that we have done before. Fortunately, our partner has a lot of experience.
How do you deal with shift changes? So you have a specific patient. There's probably not every nurse or every doctor wants to get those notifications, or I'm leaving. I don't want to continue getting those pushes when I'm home.
Yeah, it's a great question. So generally, we would just say sign off, just like your pager. Sign it off. The mobile app, actually, you can put in to your app your shift length. And so we do this for our current clients. You can say what shift you're working, the end time of your shift, and Twiage will automatically log off at that point, so you stop receiving any notifications. But that does mean that people should log in and say that they're on call when they're doing that, when they start their shift. Thank you.
Next up, we have ED Loop.
This? Okay, you have a timer going? Who? Thanks. All right, great. All right, good evening, everybody. Thank you very much for joining us today. Excited to tell you more about ED Loop. So this is a product we've been working on for the last 6 months for the Observation Unit Challenge that's designed to improve the communications between patients and providers. So why is this important? The patient-provider communication breakdown has resulted in several consequences that are very costly to not only the individuals of the patients and the providers, but also the health systems at large. This is prevalent not only in the ED and OU, however, it's especially prevalent in those spaces given the short time constraints of the units as well as the limited time of the interactions. So why does the health system need to worry about this? Poor patient communication means that the patient is clueless as well as powerless to take management of their own health care. This leaves the choices in the hands of the health system, who may not always know their backgrounds or their priorities. That's why by equipping patients with the proper education that they need in the right settings at the right times, enabling them to ask the right questions when they need to, will allow them to have a better patient experience. And in a healthcare world that's moving towards a consumer-centric model, that's important for health systems to enable if they want to stay competitive. Not only that, but the physician satisfaction piece is key. As physicians more and more communicate at below their license, they are starting to get more and more burnt out, which results in very expensive consequences for health systems. In addition, regulations are getting more and more creative and proactive about incentivizing patient communications, which is actually great for the providers because it may not just be their pain points that they can't communicate to administration anymore. Now it's an administrative pain point that they need to address as well. So all of this primes ED Loop up for the perfect timing. So when you look at the setting of an emergency room and an observation unit, it seems like chaos right off the bat, and it is. So you think about why an ER physician or an OU physician has a problem getting meaningful engagements with their patients. So largely, they start off, hit the ground running. They're doing updates of current patients. They're onboarding new patients. And then they also have to spend over 50% of their time doing mandated documentation tethered at their desk. This takes away from the meaningful face-to-face interactions that they could get with their patients, which is why they got into the profession to begin with. Because of this, EDLoop has come up with a tool to enable providers to take control of their workflows in a way that enables them to be not so responsive or reactive, but actually provides them with a way to take control of their own communications by providing text messages directly to the patient or their caregiver's phone. So EDLoop is a one-way, so no receipt of text messages by the physician, one-way physician-to-patient messaging system designed to support emergency room and observation unit communications. It's a very easy onboarding process for the patient because they opt in right when they register, and they start getting text messages right in the waiting room. This keeps them engaged. If the wait time is longer than expected, they feel more inclined to stay. Not only that, once they get admitted, they have continuous updates on the status of the labs that they're going to be receiving or why there's a delay. And this is all empowered by the physician. And this product was designed for the physician to be able to be proactive about what text messages that they want to send. So if you look to the right, you will see the dashboard that the physician sees on EDLoop, where the patient is already enrolled, so there's no onboarding process. They have the ability to immediately send them their bio and headshot so that the patient feels like they know who their caregiver will be and they don't feel forgotten. And they have the ability to send text messages through a drop-down menu that's extremely easy and on the desktop that they're probably already wired to doing EHR updates anyways. So when you think about how this impacts the patient, that workflow of the physician, you can see that their fear that they come in with is then complemented with frustration with the exasperation that they feel from not having an idea about what's happening with their care. So EDLoop is the perfect solution to figure out a way to augment the patient's engagement in their own care at the site of care that they are at. So what health system would want to improve the patient-physician interaction and why? We believe that hospitals with greater than 200 beds, so they'll have OU observation units, and academic medical centers, as well as health system hospitals, are most inclined to use a service like this because they can personalize it to whatever branding or whatever branding and messaging that they find to be relevant. This is especially important because they are thought leaders in this space, as well as forward thinkers when it comes to the consumer-centric model. And not only that, they have the ability to flex the messages that they send. So North Shore might say, hey, come to Tales from the, or come to what's next at North Shore at Matter. So it's a way for them to show that they are thinking about the patient beyond just that single point of care. So how are we going to get them to pay for this? We are going to start with a subscription model for health systems where they will pay a flat monthly fee to send whatever text messages that they would like, with the goal of demonstrating provider adoption and member and patient engagement. The idea behind this is that if both those parties are more satisfied, that will increase their brand as well as their patient retention, et cetera, likelihood to recommend. The licensing model we would then look into as a way to increase our footprint and as well as our value add to the health system. So the licensing model would be done either by leveraging the existing partnerships that we have with, or customers that we have with health systems and leveraging all the knowledge that they might have, or working with a content provider, like some sort of content provider that we would license the content from. This is an interesting opportunity for patients to see their providers actually engaging their leadership in some of the education modules. So you might see the head of cardiology explaining what a stress test is via a video that goes to the patient before they go so they can learn more about what to expect, as opposed to feeling rushed when asking questions to the physician. They can be teed up to ask the right questions. Value-based returns would be our highest reach. There's an opportunity to realize savings here as the healthcare system moves towards a system that is much more incentivized by outcomes. As we develop out the content, we can develop metrics around engagement, not only engagement, but also reduce readmissions, increase patient satisfaction scores, things that are more and more impacting the bottom line of the health systems. Some of our competition does similar things when it comes to content, providing education and then engagement. However, none of them are in the ED and observation units today. Health Loop provides services to patients when they discharge through readmissions. So there's an opportunity to kind of close the loop there. Outcome Health provides tablet-based education in the outpatient setting. That's stuff that the patients cannot re-refer back to on their phones after they leave, when they have a more clear head to think about their treatment. And Seamless Medical is a comprehensive solution for the ER that provides not only education on a tablet, but also billing and referrals. So there's an opportunity for us to actually augment their services through our unique channel opportunity by having direct access to the patient during their ED through discharge care. And this, for all these competitors, we see more of an opportunity to augment their footprint than to compete with them in this space. Our go-to-market strategy, we are starting product trials in the fall, focusing on local health, academic healthcare systems with the goal of providing metrics around adoption and engagement and satisfaction. We will then move to start to provide some opportunities for external vendors or internal vendors to provide referral services. And then once we gain some traction around that, we would be able to provide education modules that we could then potentially have payers pay for or develop out their own. So where we are in our product roadmap, this summer we are going to be working towards measuring what, or determining which capacity, determining the capacity to build the dashboards that we will need for the metric collections that we will be doing through our product trials. So we want to make, what we're focusing on is making sure our reporting capabilities are customizable, meaningful, and easy to develop with our future customers. We feel like this is important because one of our value adds at ED-Loop is that we are very early stage, so we're very nimble, and as such, we can pivot very cleanly and provide kind of very niche services in an ecosystem that's pretty hard to get started up in. So some of our anticipated risks include barriers to adoption and financial risks. So barriers to adoption, one of the main ones, resistance to changing workflow. However, we believe that not only will we identify clinical champions, but the tool is intended to provide physicians with a proactive way of managing their workflow as opposed to a reactive way. And by focusing on how we can optimize that, we believe that we will be able to overcome that. Some other barriers to adoption is that if we were to provide a marketing channel for external vendors as a source of revenue, you cannot advertise in the hospital. So we would stick to public health and healthcare related advertisements. Maybe it's discounts to flu shots or referrals to the nearest pharmacy where they have some sort of deal with a PBM. In addition to that, we would be worried about our financial risks up front because our business strategy might see low revenue up front. However, we believe that by minimizing our operational and upkeep costs, we can gain enough market penetration such that we will be able to encourage other partnerships that will supply additional revenue. We also believe that even if health systems aren't able to fund this right off the bat, we might, or in the future, we may be able to partner with payers and other providers. So our team consists of 3 very talented emergency medicine and OU physicians who all understand how impactful that provider-patient connection really is and how much they need to be equipped by the health system with operational and strategic communication systems that today, unfortunately, are just not there. Wembo from Accenture and myself were the project managers. So yeah, we look forward to a world where we can all feel like we're getting Grubhub at the ER. Thank you very much for your time. My team will join me and we welcome questions.
Hi, ED-Loop.
Eric.
How are you? Real quick. So last time I saw ID Loop, was it? Were you not sending messages to family members and sort of updating? And so this represents a bit of a shift more towards the patient, right? Patient or the caregiver. Okay, so you've sort of extended, kind of broadened the scope of it. That's cool. I see a recurring theme with integration with Redox, which is I think cool. They're one of our partners. I wanted to question you a little bit about the sort of onboarding process. What's the additional workflow up front required for the person at check-in?
Already happens in the emergency department. And so there's a manual process where a patient has to check in, provide their insurance card, license, or if they're coming. So there's a simple onboarding process where they would sign a consent form in addition to the consent for treatment that says they want to receive text messages to their phone. And then we onboard them that way through a process. And as Karina was saying, it's always been designed where a surrogate could actually be receiving the messages, and the patient's name would appear under, it's basically the surrogate, the patient's name would appear on the dashboard, but the surrogate would be underneath them and receiving the messages.
Okay. Yeah, I would just caution you about another portal that someone has to log into to get into it. I know of at least one EHR that makes it pretty easy to do some integration with on the UI. So,
just to be clear, it's not logging into a portal.
Just saying.
What we're doing is we're having them sign a consent and onboard onto their phone, where they're receiving text messages directly to their phone. So that's the big difference.
Okay.
And you know, I was able to really work with my registration team at the hospital I'm at, who was on board with the whole thing in the workflow.
Cool. All right, thanks.
Nice presentation. How much work do you see this creating for ED staff, either clinical or non-clinical? Assuming some of this is automated, but some of this must be at least manually pushed. And can you give me a sense of what type of an add this is to their workflow now?
All wanted to do it, because one of the challenges is that we're in the emergency department and the observation unit, which is often an annex off the emergency department and often maybe cared for by an emergency medicine physician. We're the face of the whole healthcare system and all the problems behind it, whether we've chosen that or not. So this really comes from my own pain point of trying to meet expectations while providing excellent care. So if I'm doing CPR in one room, the person with the ankle sprain is upset because they don't know why their x-ray is taking so long. So I designed this to be a desktop cloud application that I can minimize and pop up the screen along with you know, the radiology, everything. So I can quickly update the patient who's waiting for the x-ray to say, hey, you know, I'll be down in a minute to share with you what the results are. And so what we found is actually everybody in the emergency department, and by extension observation units, wants a tool for them to help them manage the expectations. So everyone really wants to try it, because no one really creates tools for us to manage our workflow. There's tools that are sort of created and we're said, hey, you need to use this because of this or that. The other thing you have to realize is that, you know, many physicians are employed physicians now, whether with big staffing groups or the hospital, and part of our bonuses are often tied to patient satisfaction scores. So physicians are looking for ways to manage everything, because there's nothing more frustrating to get low patient satisfaction scores from the few people that return the surveys, but not get the high scores from the person you saved their life. So this is a way to manage the expectations that fits within the workflow, because I'm already stuck at my desk doing the EHR.
So along the lines of families coming with patients, can you push these notifications to multiple numbers at once? And on the recipient side, are you eating up their text or their data, or a little bit of both? what are you instructing them as to what the impact is in receiving this?
Question. So it's designed right now just to have one cell phone be enrolled. And so if that's a surrogate cell phone, they'll be receiving it. Whether that surrogate forwards it to someone else, is written in the consent, not to do that. In terms of IT logistics, it's really getting on the hospital Wi-Fi. So certainly certain sites may have issues with Wi-Fi, but it's just getting on the Wi-Fi. And in part of the consent, there is a statement related to, any costs with texting, are up to you. So it's all voluntary to join, but there are kind of legal things you can put in there related to the costs.
As far as how much time, you talked about changes in workflow for the physicians. How is this taking a lot more time, or is it just changing how they typically do things?
I think it's just adding a tool to allow them to actually be more efficient with their time while they're sitting at their desk. This is not at all meant to replace face-to-face physician encounter. I think, again, where the problem is with physician burnout and talented people leaving the field is that they get so frustrated that, again, their bonus is tied to like the 5 people that answered the patient satisfaction score. So this, I really find that the clinicians want tools like this to help them be more efficient. And we did some beta testing at the local hospital where I had been working at, and we're going to be doing a pilot at another hospital coming up. So certainly we'll learn about, workflow challenges. I mean, any product that's created, it's not till it gets into use that you discover some, that your hypothesis was wrong in certain things. But I think because we're from the community, we have a lot of credibility. And, my motivation was I want to keep good people in emergency medicine, because if anybody here, God forbid, comes in with a heart attack or a stroke, I want good people there. And there's a lot of good people leaving medicine because they feel unsupported, because there aren't tools to help them be efficient. And also with the generation change that was mentioned, my residents sit and text and do all kinds of things in between seeing their patients. So this just piggybacks on the behavior. And so why don't we use that to, give tools to physicians to stay in medicine, and also really monetize and educate during all of that time people sit in the ER and observation units, that they're surfing Google on their own. Why aren't we, taking advantage of that time to push education material directly to their phone, push branding about the hospital, push videos,
No, that's okay. Last question. Thank you. So once you're enrolled, and I saw a little bit of this when you were talking about the configuration of it, and I wasn't clear on. Does someone specifically have to poke a button to send something, or are you set up to, say, receive sort of normal lab results may go through automatically, but obviously you'd hold on abnormal ones or something like? Have you thought about that? Is that built in?
Designed it really to make it sort of like the emergency department physicians, like the DJ. They can curate the experience, right? Because I don't get to do that again. So there are other systems out there that, hey, let's push updates, let's tell them this. Actually, that creates more expectations. Patients like, hey, my labs are back. Where's the doctor? This is about me taking more control of the environment. So we do have part of the waiting room module can spit out like send text to all that the triage nurse can do, but then once they're in the back, it's kind of piggybacked on how we sign up in EHRs. Like I would sign up for my patient, I would be able to text my patient my bio so they can read about me before I go down to the room or after I do my H&P. Then as along the hours that they're there, I can send them and control the messaging about, CT's delayed, thanks for being patient, the Cubs game just got out, there's heavier ambulance traffic. Because what we found is, patients complain about the wait time. And if you inform them about what's going on, they feel a lot better and happier.
Cool. Thank you.
And last but not least is PhysIQ.
All right, how's everyone doing tonight? My name is Jamie. I'm one of the med students here with a fantastic PhysIQ team. I'm really excited to be here today, although I feel like you can hear my heart beating inside my head. But without further ado, let's meet Frank. Frank is a 72-year-old father of 3 and grandfather of 5. When he's tending to his vegetable garden one day, he faints. His wife frantically rushes him to the emergency room where he's admitted to the observation unit. After spending 29 hours in the OU, Frank is finally discharged home with the diagnosis of low-risk vagovagal syncope and told to follow up with his primary care physician. But suppose Frank doesn't have to spend the entire 29 hours in the observation unit. I mean, nobody wants to be there, right? His wife is worried sick. His kids and his grandkids have no idea what's going on. They only know that Frank is in the OU or the emergency room and not at home where he should be. What if only 18 hours of those 29 hours were used for diagnostic testing and the other 11 hours were used for more observational purposes? Based on some conversations that we've had with various ED docs and observation unit directors, we also know that at some point, Frank is going to become non-profitable to the hospital, and on average, around hour 17, Frank is going to cost the hospital money. And he could even be sent home with a bill of around $2,000 just for those last 11 hours in the observation unit. But what if there were a better way? What if Frank could go home instead?
Thanks, Jamie. My name is Karissa Tayo. I am Vice President of Business Development at PhysIQ. And so I'm going to tell you a bit about the solution. So rather than stay in the hospital, Frank's going to be given a kit. And in this kit is a prepaid phone data plan and a collection of biosensors. And in these biosensors, we have a single lead ECG, a disposable patch that Frank is able to wear for a period of 5 days, and it allows him to be continuously monitored by his clinician. So with this patch, the system is getting continuous ECG, heart rate, respiration rate, heart rate variability, a whole slew of continuously provided vitals, streaming via Bluetooth to the phone that Frank has been provided at home. From there, the data is sent to the cloud via cellular network, and it's in the cloud that the PhysIQ analytics are doing the heavy lifting of analyzing a tremendous amount of data so that clinicians aren't in the situation of having to sit there and stare at a screen to look at these vitals all day long. I'll talk a bit more about how that works in a moment. And for the clinicians, the data for Frank and the analytics for Frank, as well as the rest of the monitored population, is provided in a web portal that is designed to allow exception-based monitoring for those patients who are outside of the hospital and at risk for potential readmission. And the whole idea here is to provide this clinical team with the insight and the data that they need to proactively manage Frank so that he can stay at home. With that, I will dive into the system here, give you an idea of how this works for clinicians. So what we've got here is our dashboard. Now, in the cloud, our analytics are taking Frank's heart rate, his respiration rate, and his activity, and building a mathematical model of his cardiopulmonary control loop using machine learning analytics. And then the system is then detecting change from a personalized baseline that's been created for Frank while he's at home. And as part of that, the system is indicating when Frank's physiology is fundamentally changing from his personalized baseline in a way that can potentially be a precursor to his health deterioration. And so what you see here would be all the patients that would be monitored within that population, that outpatient population. And as you might suspect, for each patient row here, the index is indicating that degree of personalized change. So in other words, the more blue you see over the last 7 days here, the greater the change from Frank's personalized physiological model. So that those patients were, you see a low index, their physiology is behaving as expected. Those patients who have a higher index, their physiology is fundamentally different than what the system is expecting based on machine learning analytics. In essence, that provides a triage solution, right? It's a way to understand who within the monitor population do I as a clinician need to understand where to focus my time and attention. And so by clicking on Frank's data then, I'm able to drill down into the real-time vitals that are offered by the system. Now what's interesting, so this is Frank's data here, or actually it's a real patient, but it's not Frank. And what we see is that we've got heart rate, respiration rate, his activity, we've got our AFib index, we've got his posture, we can understand his sleep, Cheyne-Stokes respiration. We can understand all these things about Frank's physiology. Now what's particularly interesting here for this patient from one of our clinical trials, in an observational setting, this patient, as you might note right here, went into AFib. And this is the kind of visibility and power that's possible with continuous clinical grade physiological monitoring. So it's in this situation that someone would have the opportunity to engage Frank, get him back in the hospital, so that this can be addressed. Now, I think it's important to note that this whole solution and system is FDA cleared. The patch, the wearable patch that Frank has is an FDA cleared patch. The analytics that provided here by PhysIQ are also FDA 510K cleared. With that, I'm going to turn it over to Blake, who's going to share a little bit more about the types of patients that we believe can benefit.
Hi, my name is Blake. I'm also an M1 student at Loyola. So essentially, we wanted to ask what patient populations would potentially benefit from using this patch, benefit from the remote monitoring. Even as an M1 student, we understand that the emergency room can be a really high-risk place additionally with the observational unit. So we wanted to identify those low-risk, high-yield patient populations that wouldn't necessarily have as many risk factors if they were to leave the hospital. So based on what Chris said about our kind of continuous monitoring and analytics, we identified some potential patient populations that would benefit from this patch, including low-risk chest pain. Chest pain is a huge thing right now, and we understand the severity that it can bring. But there are situations in which low-risk chest pain is identified. Syncope, non-decompensating congestive heart failure, respiratory illnesses such as acute exacerbations of COPD and asthma, along with atrial fibrillation and cellulitis. So in total, these patient populations represent approximately 33% of the people coming through the observational unit. Last year, 138 million people visited the ED. Subsequently, 2.89 million people were admitted to an observational unit. That means that we have the potential to monitor 1 million people coming through observation units for this remote monitoring. To increase observational throughput, what we're theorizing here is that we send these patients home. They don't need to spend time in the hospital. We theorize that there's an opportunity to save time and money for patients, physicians, and hospitals nationwide.
Thanks, Blake. Last but not least is our go-to-market strategy. Here at PhysIQ, we want to target hospitals that have provider-sponsored plans and integrative delivery networks. All that really means is we want to target hospitals where inpatient and outpatient physicians are on the same team, a team where they want to deliver, they're incentivized to deliver quality care at value-based care at low cost to the patient and the hospital. So within these hospital settings are both decentralized and centralized observation units. We believe that the patch could target both kinds of observation units and offer a sense of priority and way to increase the dispatch ratio. Centralized observation units tend to be more efficient, but they could use this product as a way to prioritize their patients. Decentralized units have a lot more pain points because they run on a scattered-based model. So we think that it's our responsibility to go in there and help them out as well. Next, we like to target an urban market setting where hospitals are at the center of densely populated area for obvious reasons. It's important that our business model is an end-to-end solution so that we offer the user interface, the physician interface, all the data analytics, the software that Chris talked about, in one package that's a pay-per-patient type solution. So the hospital only has to pay for what it wants and when it wants to use it. Finally, we had it was interesting to think about who we could potentially partner with. And the most obvious answer is companies that are already in the transportation and healthcare delivery market. So companies like Dispatch Health, who is already responding to healthcares across the country, and also transportation units like Uber, where we probably all have maybe grabbed one here tonight. Getting from point A to point B is as easy as pulling up an app. So I just want to leave you all with one thought. Tonight we heard a lot about the problems of the observation unit, and we've heard 3 great solutions. But what if we lived in a world where cold, noisy, possibly contagious observation units weren't the only place where people could experience the power of healing? What if we could put that patch on Frank and send him home with an unsurmountable sense of peace of mind and safety? Well, this is where healthcare is headed, and PhysIQ can't wait to be a part of this mission. Thank you so much for your time.
So your model, you have a Bluetooth connection through the patch to a cell phone.
That's correct.
In the home. How do you plan on dealing with patient compliance when they're back in their home environment?
Yeah, see, the beauty of continuous monitoring like this is that you actually know every minute if somebody's wearing a patch. So that's constantly visible. The system's also set up with automated alarms in the event it detects that a patient is either out of range from the phone, or they've taken their patch off, or the phone's battery has run out. So in our, just as a reference point, in our clinical studies to date, where we're actually applying this in a post-acute setting, where patients are wearing it for 90 days post-discharge, compliance rates are upwards of 75%, meaning 75% of the minutes over those 90 days, they're actually wearing the patch.
Means go. Thanks. Kind of along the same kind of line of questioning that I had before, kind of about workflow integration. You know, so EDs and OUs and most acute care settings have enough of a problem dealing with the patients that are there, much less dealing with some set of population who's not. Who's watching the board, or who's waiting for those alerts to happen? Is that something that's more fitting for, I mean, you mentioned post-acute, something I'm thinking like care management, what's really above the core clinical systems. That was one side of it. Secondly, it sounds like you're pretty well along from a funding perspective. I'm just curious about that. And then I had a third one, but Chris is going to take it from here.
Yeah. So as it relates to the workflow piece, I think you're absolutely right. Right. It is it's required to have some sort of infrastructure to be responsible for these patients. That's actually going to be a key filter in the go-to-market. There are some systems that are set up that way, and others who are not. In our conversations with clinicians, for those systems who don't have kind of an umbrella care coordination group, one of the ideas was actually the telemetry unit in the hospital could be leveraged for this type of monitoring. Does that address your question? And then as a follow-up, yeah, we are a Series B venture capital backed company. Yes.
No. So the idea being a per patient.
Correct. Yeah. I mean. You know, and we are actually working with hospital systems now and payers the key with the payers is who's actually going to do that monitoring, or to the degree it might be if it's not reimbursed, right? So this currently is not a reimbursable thing. So that's why we focus on value-based systems, and that's a market by market challenge to address.
So using this patch to establish a baseline for the patient in the immediate post-hospital phase is probably not exactly patient baseline, but you can get to there once they've stabilized after that. Is there any way to save this data and import it either into the EHR or have it available as a comparator for a re-presentation to the hospital to see how far askew they are from baseline after they've already completed their phase of patch monitoring?
Yeah, so it's a cloud-based solution. All the data stays in our cloud. Traditionally, this type of continuous telemetry data is not actually captured in an EHR, at least not right now. Let's talk. So all the data never goes away. The baselines, all the analytics never go away. What the interesting thing is too is that we have an adaptive rebaselining algorithm, or adaptive rebasing is part of our algorithm. So as patients change, our system's actually able to kind of meet them where they are and continue to raise the bar for them physiologically speaking as they improve. So we've got certain deployments now where we're actually sending a patch per month to patients, so we can actually see how they're changing over time from that first model that's been developed for them.
And for that 25% of patients who were not wearing the patch at some point in time, what was the system's response to a flatline telemetry response?
Yeah, so it's not that 25% of patients didn't wear it. It's that over the course of 90 days, right? So the system basically says, all right, person's not wearing a patch. So it's not a flat line. It's saying they're not wearing a patch. And there's
it knows the difference between the two.
Oh, yeah.
Okay.
Yeah. We know a lot. The system knows a lot. It's got a lot of analytics built into it. Thank you.
Okay, thank you all very much. Those were great presentations. The judges are going to go sequester themselves for just about 10 minutes to determine a winner. Is there a Carolyn Cotter in the audience? Hey, come on up. So just while the judges are deliberating, we thought we'd introduce a friend of Matters. Carolyn Cotter is from the Medical University of South Carolina and doing some interesting work in the observation unit space. So I thought we'd just give her a few minutes to share a little bit background and an introduction. Thank you.
Hi, my name is Caroline Cotter, and I'm with the Medical University of South Carolina in Charleston. We're about a 700-bed medical center, and we are doing a lot of work around innovation with observation care. So we have an opportunity. We're building a new children's hospital on our campus, which allows us the opportunity to backfill that building with higher acuity inpatient services to really support our academic mission. And with that, we have space. So I'm in strategic planning and facility planning. So we're trying to be innovative about how we use this space and ensure that it meets our patients' needs. And we've seen about a 46% growth in our observation care over the past 3 years. So a lot of the changes in regulations has impacted this, but when we heard about the Matter Challenge and we started to work with some of the teams, we found some great insight, and our clinicians really enjoyed learning about a lot of these solutions. And as we prepared for this observation unit, we're thinking about having a unit as part of the emergency department, but also there's the observation care for surgical patients. So those patients that come in for the 23-hour surgeries, and we need a place to hold them so that we're not taking up inpatient beds or taking up space in our PACU. So trying to think about kind of two different concepts. So the surgical observation care, which is something that I'd love to speak with some of you all about, and then also the observation care as it connects with the emergency department. So huge opportunity, and I think a lot of the business model and planning around it is going to be, and we're going to be able to backfill those beds. So we currently have observation patients sitting in our inpatient beds, and patients waiting, days to get a bed. So we're at capacity and have a lot of challenges. So a lot of opportunity there and a lot of innovation with this space. And we're the only academic medical center in the state, so we have a challenge, and we have the higher acuity patients that come throughout the Southeast to our hospital. So it's been a great partnership. We have an innovation center at MUSC that has really just launched. We actually just partnered with Apple and have opened a Apple store on our campus. It's called the Innovation Station. So just hearing about this last concept, how we can have our patients to connect with technology and use, we're thinking about having our physicians write scripts to send our patients to the Innovation Station for some type of, apps or ways to track their health. So I think it'll be great opportunities. Look forward to the partnership in the future. So thank you for the opportunity.
So the judges will be back momentarily. We encourage you there's some food and drink remaining. The only ask is that you please stick around. They will be back shortly, and we will unveil the winner of the challenge. So thank you, guys. All right, everybody. Wow, there's no. Okay, can everybody take a seat? We're going to announce the winner. Please come back to your seats. Can everyone make it back to their seats? Okay. Decision time. So hopefully we will avoid any Steve Harvey Oscar moments here. But thank you all once again for being here, and thanks again to all the teams. So I will turn it over to the judges.
All right, everybody. Well, what an exciting endeavor to be a part of. I wanted to thank everybody here for having all of us participate in this. It's been a grand learning experience, and I apologize, it took us a little while. We had to stop his bloody nose after the fight down that we had back there. So I want to congratulate all three of the teams, but at this point we have arrived at a consensus. I would like to congratulate Twiage. You have successfully met the observation unit challenge, so congratulations, everybody.
Thank you guys very much. We welcome you back to Matter anytime. Thanks.